Hello, everyone. Oh, wow, that's a lot louder than I expected. All right, well, welcome to our spring hybrid meeting in 2023. Thank you all for coming today. My name is Carmen Chinchilla, in case you haven't met me, but I'm your executive director, so I'm glad that you guys were all able to make it today. And with that, I'll let our president, Dr. Thompson, come in and introduce tonight's event.
People online.
We do. Dr.
Okay.
Lintel and so online we have Dr. Lintel and Dr. Lacey.
Okay, well, welcome everyone. Thank you for coming out tonight to hear the talk. We are pleased and grateful to Dr. Lazenby for coming to give us the talk tonight. Dr. Lazenby attended medical school at Johns Hopkins in Baltimore, followed by residency in anatomic pathology at Barnes Hospital in St. Louis. She followed this with a fellowship in surgical pathology at the University of North Carolina in Chapel Hill, then a fellowship in GI pathology back at Hopkins. After fellowship, she was on faculty at Hopkins for 8 years, then on faculty at UAB for 10 years, and she is currently faculty at UNMC, where she's the director of the anatomic pathology. She's past president of the Gastrointestinal Pathology Society and received the Harvey Goldman Lifetime Achievement Award from GIPS in 2019. For USCAP, she has been on the education committee and was on the board of director for 3 years. She's currently on the council for the Association of Directors of Anatomic and Surgical Pathology and is on the medical executive committee at Nebraska Medicine. So welcome, Dr. Lazenby, and thank you so much for agreeing to speak with us tonight. Get you loaded up. Thank you.
Great, thank you very much. I'll stand up here so I can see there and use my pointer. Well, I really appreciate the. Oh, okay, I'll do that. Sorry. Thank you. There we go. Okay. So thank you very much for the invitation. I'm pleased to be here to talk to you tonight. I thought what I would do is just talk about some cases in the upper GI tract. There are uncommon cases, but they're not vanishingly rare. So they're the kinds of cases you're going to see, just not very commonly. And, you know, I'm just a card-carrying GI pathologist. And so what I do every day is casework. I get the history, I look at the slides and try to figure it out. So I thought I'd just present it to you as the way I do my work every day, and the way you do your work every day. I'm looking at cases. So my first case is a 72-year-old prison inmate who had GI bleeding and hematemesis. Endoscopy showed whitish areas that were clinically suspicious for Candida. And what you can see on this esophageal biopsy, I think very readily, is that there are sort of two colors to this mucosa. There's a top pink layer and a lighter blue layer. If you go a little higher, you can that highlights that two-toned appearance. You have the superficial pink layer, which is probably damaged. That's why it's pink. And one of the reasons you can recognize that it's damaged is because what you can see beneath it and between the more normal layer below are clusters of neutrophils. In some places, there are a lot of neutrophils in between those two layers. And what you can also see is now this top damaged pink layer is starting to separate from the more healthy layer below. even more separation there. And then we also had just strips of the detached epithelium. And so what this is sloughing esophagitis, also known as esophagitis dissecans. I have a picture of a snake skin there because that's kind of what it seems to me like. You have sloughing off of that superficial epithelium. It has a very dramatic endoscopic appearance, but it's got a very varied endoscopic appearance. On the left, you can see that there's just this white plaque, and the clinicians often think of Candida when they see this case. This type of appearance. It's not done that much sloughing, but you can see here, there is this sort of denuded area, so it has started sloughing. Here's a case where they recognize that it was sloughing esophagitis because they can see strips of it coming off. You can see the strip coming off here. And sometimes there's a tremendous amount of this white material on the surface. So you can see that this whole surface is sort of coated with this white area. So this is the eosinophilic damage layer. And here you can see it's come off and there's this little strip that's sitting on the side. You can see it's peeled off here as well. So as a, when it's very advanced, it has a fairly classic endoscopic appearance, but I would say most cases of sloughing esophagitis, our clinicians don't recognize because it may be like that little white plaque, or like this case was so much that it was beyond what they were used to seeing. People don't truly know what causes sloughing esophagitis, but it is presumed due to topical damage, because you see that surface damaged epithelium. People talk about various medications, hot liquids, any number of things, but many of the patients who have sloughing esophagitis are taking many, many medicines. So I don't know a specific medicine that's been associated with this. And many of these patients are hospitalized, and so they are lying down. And so it may just be acid plus all these various medications damaging the surface. So in real estate, it's location, location, location. In this disease, I think the location of the neutrophils is very helpful to recognize a disorder. In most of the disorders where you see neutrophils in the esophagus, you're going to see those neutrophils up in the surface epithelium. So here is a Candida case, and you have these superficial neutrophils. There's some Candida over here that I didn't actually include in the biopsy. Here you can see the neutrophils in between this pink and bluer level. So between the layers is the place you see it most often. And sometimes it's very helpful because if you just got that superficial layer that's come off, if you look at the bottom of it, you'll find the neutrophils. So this is a case I saw on Monday. And this pink layer is really had only a tiny bit of underlying mucosa, but this pink layer you can see is very damaged at the bottom, and there's some neutrophils at the bottom. So if you have a detached piece of mucosa where you're not seeing your basal layers, look at that bottom layer to see if you see some neutrophils, and that may give you a clue that you're dealing with sloughing esophagitis. So recap, sloughing esophagitis has two-toned epithelium, the pink layer over the more blue layer. Very important to look for those neutrophils between the layers or the base of the layer. That really is helpful in the detached fragments. The differential for the clinicians is usually Candida or epidermoid metaplasia because it's white. And we believe it is caused by topical damage, so we don't really know what the specific agents are. Second case has a shorter history, a 72-year-old woman with dysphagia. And what you can see is we have a thickened mucosa. And even at this power, you can see there's a tremendous number of intraepithelial lymphocytes. They're around the vascular papillae. You can also see a few of these bright pink cells, which are dyskeratotic cells. Higher power, again, lots of lymphocytes. If you stain them, they are mostly T cells. Strangely enough, they're mostly CD4 cells. I tend to think of intraepithelial lymphocytes as CD8, which in the luminal gut, but these are usually CD4. I don't stain them, but just as an aside. And here again is a dyskeratotic cell. So, here's another, the dyskeratotic cell actually shows up a little bit better here. And so this is a case of lymphocytic esophagitis. It seems like every couple of years, somebody gets a small case series of 10 or 15 cases, and everybody gives it a different name. So you'll see all kinds of names for it: lymphocytic predominant, lymphocytic rich esophagitis, lichenoid esophagitis, lichen planus like esophagitis. I think they're all the same thing or variants of the same thing, but they just have go by these different names. And what you're looking for are very high numbers of IELs. You normally have IELs in squamous mucosa, so you're really looking for very high numbers. There can be dyskeratotic cells. They're usually pretty rare. I think the most important thing about this disorder is that it is a diagnosis of exclusion, because you can see high numbers of intraepithelial lymphocytes in many conditions. You can see them in Candida, you can see them in reflux, EOE, Crohn's disease, particularly in children who have Crohn's disease. To make the diagnosis confidently, you want to see these changes in the proximal esophagus. So you can rule out Candida with your GMS stain. You're going to recognize EOE because of all the eosinophils. You use your clinical history for Crohn's disease. And the way you're ruling out reflux as a cause of the IELs is that you're having the changes extend to the proximal esophagus. So just as an example, why you have to rule out other conditions, that it's a diagnosis of exclusion. On the left, you see the H&E, where there again are a tremendous number of intraepithelial lymphocytes. Here on the right is a GMS stain showing that there were yeast and hyphae consistent with Candida in that squamous mucosa. And so when you strictly define lymphocytic esophagitis, there is a clinical pathologic disorder. It's most often seen in middle-aged to elderly women. The patients have dysphagia, they have difficulty swallowing, and it may respond to steroids, the dysphagia. Often these patients have other autoimmune diseases, including lichen planus. One of our recently retired pathologists, his mother-in-law had terrible dysphagia. She was losing weight because she couldn't eat. Did the biopsy, we call it lymphocytic esophagitis. She was put on steroids, and it just made an enormous difference in her life. You know, she could eat, she gained her weight back, she felt much better. So even though it's kind of hard to work out all those other causes, it's worthwhile trying to make the diagnosis of lymphocytic esophagitis because of this small fraction that really have a very significant clinical problem that really can be managed with steroids. So a recap on lymphocytic esophagitis: lots of IELs, dyskeratotic cells. It's a diagnosis of exclusion. Many things will give you IELs, so you've got to exclude those conditions. Most often, if you've done all those exclusions, it's middle-aged women, autoimmune disorders who have dysphagia, and they can get significant relief with steroids. Case 3. This was a 59-year-old man with a history of alcoholic cirrhosis and anemia. Upper endoscopy showed esophageal varices, portal gastropathy, and multiple polyps in the antrum. And biopsies are from these antral polyps. So at low power, what you see is that there is a foveolar process, or there are these elongated tortuous foveoli. So that makes you think that it's a hyperplastic polyp. But your hyperplastic polyp should have, the lamina propria should look more like this. This, on the other hand, has a tremendous number of blood vessels, lots of little blood vessels, some medium-sized blood vessels. On higher power, you can see that even better. The lamina propria is just sort of wall-to-wall blood vessels. And so what this is a new type of GAVE, gastric antrovascular ectasia, called the nodular type. So the classic GAVE that we all know about, the one that gets the name of water-balanced stomach, has these longitudinal red stripes extending up from the pylorus. So those red stripes are like the green stripes on the bottom of the watermelon. Another classic appearance is a punctate erythema, but this new variant really looks quite different. There are nodules, there are hyperplastic polyps. And as you read the endoscopy report, someone will talk about these reddish polyps that are oozing blood. So this on the left is the classic appearance of a watermelon stomach, those stripes extending up here from the pylorus. Here on the right is the punctate form with little separated hemorrhagic areas. And then here is this new form, this nodular gabe. And clinicians are just now starting to recognize this. Mostly they're thinking this is a hyperplastic polyp. They may or may not biopsy it, but it is important for them to recognize it because this is one of the places where it's bleeding and where a cause of the anemia in these patients. So the nodular type is a little bit different clinically than your more classic types. There is a significant amount of patients with cirrhosis, 30%. It is more common in women. Our patient was a man. It is associated with blood loss and anemia. And as I said before, the clinicians may not recognize it. They may just think they're hyperplastic polyps. But when they do recognize it and they understand that it is causing the blood loss, the therapy is ablation. They'll laser it or use radio frequency or whatever they do to kill it these days.
So these people with the nodular form, are they more likely to have esophageal varices than the other two?
Well, I would assume so, since there's more cirrhosis in this population. But of the, I don't know that specifically. There's not that many reports on it. This particular patient had varices as well as these nodules. So since it's more common in cirrhosis, I assume there's a fair frequency of varices. So just for comparison, here's the classic gabe that you might see either with the stripes or the punctate forms. And what you see are these dilated blood vessels. This has got a lot more than you usually see. In your report, in the literature, classically, they say these individuals, you're looking for a fibrin thrombus. I think I almost never see them. So maybe you're better at looking at finding than I am, but I rarely see those fibrin thrombi that are classically described. But the nodular form of gabe has many more blood vessels than this, lots of little tiny small blood vessels.
And either of those, do you actually top line it and sign it out as such, or do you give it a descriptive diagnosis with a comment that it could be that?
I think, well, I read the endoscopy report and they see a red polyp and I see this many blood vessels. I don't know anything else that could be. So I top line it as gastric antrovascular nodular type. I do. And I guess, seen 2 or 3 cases a year. We may see more of it because we're a transplant unit, and so there's a lot of people with cirrhosis that we see. But I've seen a number of these now. So how do you get this antrovascular ectasia? There's sort of 2 theories. For the classic type, it's usually thought to be mechanical factors. The mucosa prolapses, and that leads to blood flow obstruction, and that can then result in vasodilation and proliferation of these little small vessels. In the cirrhotic patients, another thought is that because your liver is cirrhotic, you're not metabolizing various biochemical factors, which may be vasoactive. So maybe different pathogenesis of the 2 forms. Okay, so recap. This is nodular gabe. It's a new form that really is very distinctive grossly with these red polyps. It has more numerous vessels compared to classic gabe. It's associated with cirrhosis and it's treated with ablation. Case 4. This is a 16-year-old woman with abdominal pain. Endoscopy showed nodular mucosa, and the clinician suspected Helicobacter gastritis. You know, you get big lymphoid aggregates in Helicobacter, so he saw these nodules and he thought, well, this is probably Helicobacter. And that's, as you look at it, it's one of the things you could be thinking about because this clearly is a chronic gastritis. There clearly are way too many plasma cells here in the lamina propria. There are also a lot of eosinophils. But what you can also see is a subepithelial collagen band with some intraepithelial lymphocytes. As I was going through our records looking for cases of this to show you guys, every single one of them was maloriented. So I'm sorry it's maloriented, but I couldn't find one that wasn't maloriented. So that was sort of a glancing blow here that makes the subepithelial area look a little bit thicker than it probably is. And here is another area of the same case where you have this subepithelial collagen band. There is a chronic gastritis, too many plasma cells, too many eosinophils. You'll also see that the epithelium is coming off here, which is classic for these disorders that have a subepithelial collagen band. Just another view. This one is the best oriented, which is maybe the band is, this is probably the correct thickness here. Here, sorry. And so this is, oh, I go the wrong way. This is collagenous gastritis. Now, we do Helicobacter stains on all our children's cases, and the IEC for this was negative. Sorry, I'm not sick, I just coughed. Right. Maybe I'm through. All right. So collagenous gastritis is more common in children than adults. And in children, it's usually an isolated lesion. In adults, they may also have other collagenous disorders, including collagenous colitis, collagenous sprue, and celiac disease. The symptoms are not very specific. They include abdominal pain, which I think on every endoscopic requisition we get is abdominal pain. Everybody's abdominal pain. And they have iron deficiency as well. And what this brings up for me is a problem that's not too infrequent. When you see a chronic gastritis and the Helicobacter stains negative, you look at this thing and you say, this really ought to be Helicobacter, but the stain is negative. So the number one thing I think is that the patient could have Helicobacter, but because they're on proton pump inhibitors or on antibiotics or bismuth, it has altered things enough that you really don't see, you can't find Helicobacter. So on cases like that, I often write in a comment, say, the histology looks like Helicobacter gastritis, but my stain is negative. And if the patient is on proton pump inhibitors or certain other medications, it may be difficult to find the organism on biopsy. So I think a lot of the times when you have chronic gastritis, it may be Helicobacter if the patient is on therapy of some kind. But in the differential is this kind of case I was just showing you. Collagenous gastritis as a chronic gastritis. Another one would be lymphocytic gastritis. And I think the most common one I think that you will see is autoimmune gastritis. So when you have a biopsy of the body, a lot of inflammation, lost your Prahlin sheath cells, you have autoimmune gastritis, that's an explanation of this chronic gastritis that's negative for Helicobacter. And then you can have upper tract IBD that will give you some chronic gastritis in your stomach. So to recap, this is a case of collagenous gastritis, which is more common in children. It is a definite chronic gastritis, lots of cells in the lamina propria. You have the subepithelial collagen band. Some cases have a lot of IELs, many do not. And it should be your differential for chronic gastritis that is HP negative. So if you have a grip-borne chronic gastritis, just take a peek up under the epithelial layer to see if you might have that collagen band. You'll also see a pink layer up under that collagen band, up under that epithelium, though, in those real acute erosions of the stomach when it's fibrin, but those usually are not very inflamed. And they can have other collagenous entities as well, particularly if it's an adult. Case 5, a 70-year-old man on pembrolizumab. You know, I really don't like the names for all these drugs. They keep many syllables, umabs, and they just keep getting longer and longer. They're really hard to say. So Pembro, 70-year-old man on Pembro, this one's not so bad. Some of the other ones are worse. So he's on pembrolizumab for metastatic renal cell carcinoma. He developed very, very severe diarrhea. And so the clinical requisition says, rule out checkpoint inhibitor colitis, which is a reasonable thing. So what you can see on this low power shot is that there is villus blunting. The light should be up here to the top of the screen. They're definitely blunted. There is a mild increase in intraepithelial lymphocytes. There clearly is too much inflammation in the lamina propria. On higher power, you can see this, the shortened villi, the villus blunting. You have a subepithelial collagen layer, and you have some scattered IELs. And just like as I was showing you in collagenous gastritis, you're having detachment of the surface epithelium. So that's common in all of these collagenous entities, collagenous colitis, gastritis, collagenous, this is collagenous sprue. That epithelium peels off of that collagen layer, and sometimes you just have a bald mucosa. You don't see epithelium surviving at all. So this is collagenous sprue related to losartan, which is an angiotensin II receptor blocker used for hypertension. So on a historical note, these patients, they've been around for quite a while with collagenous sprue, have terribly severe diarrhea. Diarrhea that is like on the level of cholera. Such bad diarrhea that people get dehydrated and get MI secondary to the dehydration because they're very volume depleted. And because the biopsy showed villus blunting, it was thought to be some weird variant of sprue. But it was recognized from the very beginning that the serology was negative and they had no response to a gluten-free diet. So they were studying these cases at Mayo Clinic. They had people come in, they were hospitalized. And when they were hospitalized, they would take them off various medications. They were on drugs for hypertension. They were so volume depleted, they were no longer hypertensive. And they seemed to get better, but they were doing all kinds of different things. They didn't put 2 and 2 together, that is, they were taking off the antihypertensive medicines, so they had steroids and all these things. And then when the patients went home, one patient then got put back on these medications. He got put back on an angiotensin blocker, got back on olmesartan, and he recognized himself that I was doing better off the drug. I got on this drug and I got worse. He called them back up in Mayo Clinic. They then went back and looked at all their cases and it was like, aha, that's what this is. So it's pretty neat that a patient kind of figured it out, I think. So it is due to angiotensin II blockers used for the treatment of hypertension. The first drug that was it was related to was olmesartan. And so most of all the early case reports describe this related to olmesartan. But any of these sartan drugs do it. There's a whole bunch of them. Valsartan, losartan, there's just bunches and bunches of them. And just like with collagenous gastritis, these individuals can have other collagenous entities as well. They can have colitis and symphysis colitis gastritis as well. So how this drug causes this picture, I have no idea. I assume it must affect the vasculature. And there are little blood vessels right up under that subepithelial layer. But as far as I know, nobody's figured out how this drug causes this histology. So to recap, this is a case of collagenous sprue, where you have villus blunting, this subepithelial collagen layer, a little bit of IELs. It's really not the high level that you see with classic sprue. Like all the other collagenous entities, you can have detachment of that surface epithelium, that bald mucosa. So it's due to the sartan antihypertensive drugs. And as I went over the histology, and they can have collagenous problems in other parts of the GI tract as well. Case 6. This was from a 41-year-old woman with recurrent upper respiratory infections and diarrhea. This has some resemblance to the case we just looked at, because there is some villus blunting, some definite villus blunting. I think, though, what you can see is there are more IELs in this case. There are lots of intravenous lymphocytes here. On higher power, this on the left shows really that's a lot of lymphocytes. Usually, so when I'm evaluating a case for celiac disease, I look at those villus tips. If I have 6 to 10 lymphocytes up in that tip, I start thinking about celiac disease. So this is in that celiac disease range easily. But if you look over here on the right, this is a funny looking lamina propria. You have some muscle bundles. I think you have some macrophages, maybe some mast cells, but you really don't see any good plasma cells. And just to emphasize that fact, this is a CD138 stain, which is staining the epithelium, but it is not staining any plasma cells. You know, your lamina propria should be chock full of plasma cells. That's the main cell that you see in the lamina propria. So no plasma cells, which then gives you the diagnosis of common variable immunodeficiency. So this is not a single disease, but a group of diseases characterized by markedly decreased immunoglobulins, resulting from many different genetic defects. Recurrent infections are the most common clinical problem, but autoimmune disease and chronic lung disease are also common, probably the lung disease from recurrent infections. And this disorder is a great mimicker. Clinically, they are thought to have sprue because they have watery diarrhea and malabsorption. Some of them have a more IBD-like picture with bloody diarrhea and abdominal pain. But not just clinically, but pathologically, it's also a great mimicker. I just showed you, it really looks a lot like celiac disease. There are some cases that are GVHD-like, at least in the literature, with a lot of apoptosis. I've not seen those myself, but the literature does describe that. So a recap. This is common variable immunodeficiency. It's a mimicker of various other disorders. It's celiac-like, usually. It's what I've usually seen with blunting and increased IELs, but it can be GVHD-like. And the clue is to recognize what is not there. There are no plasma cells in the lamina propria. That's actually, I think, one of the harder things to recognize is what's not there. You're trying to see what is there. I don't know how many of you watch the Disney Channel, and you may not recognize it, but that's the Mandalorian with this Nebraska hat on. Okay, case 7. This was a 77-year-old schizophrenic woman who came to the ED for abdominal pain. CT scan showed, and I'm quoting, proximal and distal transitional points, raising concern for closed loop obstruction or internal hernia. I think that's radiology speak for obstruction. I think that's what all that's about. And this is sideways because I could fit it up this way very well and still have it at the right magnification. But what you see is this is the top of the fold. And between the muscularis mucosae, this is what the submucosa should look like right here. But between the top of the muscularis mucosae, there's this column of fibrous tissue that is extending the mucosa up in this area. That one was a real tall column. Some of the other areas, there were just these little nubs that were sticking up out of the mucosa. And when you go and look at these nubs or these columns, it's really not very exciting. It's just a bunch of fibrous tissue, and it's not really very inflamed. It's just fibrous tissue in a funny place, making this tall column. And so what this is diaphragm disease related to insects. And what's more striking than the histology is the growths. So what you see up on the top left, being held open with some forceps or some retractors, this is a diaphragm. This is a diaphragm. This is a diaphragm. So you have really, really narrow strictures. You know, the Crohn's disease stricture are these long, narrow strictures. Ischemia is these long strictures. Diaphragm disease is really, really short strictures. And you could actually see on the outside of the colon, you could get a sense of where those strictures were. You can see how it sort of comes in here. So these are where the strictures are. So in retrospect, we realized what it was from the outside, but we actually didn't recognize this until we cut it open. And it can cause dramatic narrowing of the lumen, particularly here you see on the here you see on the right that there's only a little tiny couple millimeter hole. This is an endoscopic appearance looking in to an area of a diaphragm. And I love this picture. This is from the British. Somebody was really smart that figured out what was going on, because you had to cut this in a really special way. So I think they had a couple of these cases, and by the time they got this one, they kind of figured it out. So what they did was they inflated the bowel, and then they cut out these little windows. But I think this really shows the diaphragms better than just about anything. So here you can see, here's a diaphragm here. That's that narrow, narrow stricture down here as well. So I just, somebody's smart to have thought to do that ahead of time. I just see them after they cut open. So the gross findings, there are multiple short strictures, and it can reduce the lumen to a few millimeters. The place you most often see this is in the distal small bowel, but it can also involve the proximal colon. Clinically, these patients have partial small bowel obstruction, and I don't know if you remember from medical school, but I remember being taught that this is one of the things that people don't diagnose for years, because somebody has a partial small bowel obstruction, they have abdominal pain, bloating, they feel bad, and make an appointment with their doctor, but because they feel bad, they stop eating. And so it sort of treats their obstruction. And they come in and they can't find the symptoms anymore. You do a flat plate or whatever, and you don't see the air. And so it just keeps on going till it gets worse and somebody finally figures it out. But this causes partial small bowel obstruction. I guess the 2 or 3 cases I've seen over the past couple of years, one of the ones we got was because the patient had some degree of obstruction. So they took a pill cam. So they swallowed the pill cam couldn't go through. So you had to take the bowel out because there's pill cam stuck in it. It's kind of like being on an Easter egg hunt. You open it up and whoop, there was this pill cam sitting there in the middle of it. So it's usually not suspected clinically because of this partial small bowel obstruction. So this is a recap, that it is more impressive grossly than it is microscopically. So here are our diaphragms, and it really is just a column of fibrous tissue up on the fold. The histology really is pretty subtle, and actually the gross can be, I think that's pretty subtle as well. In fact, small bowel is the most common site, and it's insect related, so it's usually not inflamed. I don't know if you noticed it, but I had most of the good guys were wearing red Nebraska caps. This is the bad guy with a not Nebraska hat. What causes, how does it do that? I don't know. I know insects cause ulcers. Why does it cause these ulcers on the tops of these folds? I don't know. I don't know that it would have to be that excessive.
Is there any particular insect
Nope,
it's associated with?
not that I know of. Ben, do you have any insights on that?
Nope.
No.
We're all getting worried here.
Pretty Okay, and that's it, and there's some references. Okay, so this is the end. And I really not talked to you about zebras. You know, zebra to me is something you might see once in your lifetime, or you'll see it at a talk at a major conference, and you'll never see it. You will see cases like this. You will see these. You'll only see 2 or 3 a year, but they're out there, and you will see them. So I hope you enjoyed seeing some uncommon but interesting upper GI tract regions. Okay.
I did, as a non-medical person. I know that there's been an increase in autoimmune diseases being found in the population, and will that translate to more of these type of diseases in the GI tract as well?
Well, I think the thing that we're seeing now more than we've seen before that has an autoimmune look by histology is drugs. There's so many of these checkpoint inhibitors or immune modulator drugs. They give an autoimmune-like picture with apoptosis and increased IELs. But I would say that's not something I diagnose in autoimmune neuritis very much. So I think autoimmune disease may affect more of the skin or some other spot, but I really don't see that much autoimmune disease that I can label it as such in the GI tract. Some of these patients have they may have an autoimmune propensity, but I don't see an increase in autoimmune disease, really. Yeah. Okay. Thank you.
Oh, and
Yes.
before I move it and it does some feedback thing, I figure I should shut it off. And of course, we want to thank our industry sponsor, our industry partners today for joining us, and that would be Genentech, Caris Life Sciences, Castle Biosciences, Astellas, and CSI Laboratories. So thank you guys so much for your support. And thank you, of course, to our speaker, Dr. Lazenby. And I didn't check, but I'll check with our online folks to make sure we didn't miss any questions. No.
You know, Carmen, I might ask you a question.
Yes.
Probably everybody knows this, but me, how soon, can you hear me okay?
Yes, we can.
Yeah, this is Steph Lacy. How soon does Helicobacter disappear after PPI or bismuth therapies? If you put that comment in there, how soon does that happen?
Oh, so Ben says if you follow live, 6 months, it may be gone, but I don't know that I do not know that. Do not know that. Yeah. And one of the things that. Chris, so really, I'm not sure of any, I know of a study that does that, but it, as Ben says, sometimes it's 3 to 6 months later when you have the biopsy and they're gone. So I don't know when it first starts. But one of the things that the clinicians can do to help you is that they biopsy not just the antrum, but also the body, because then you've got a greater chance. So my clinicians don't do that. They take one little piece of the antrum. But if you have multiple pieces of the antrum and multiple pieces of the body, you're more likely to find that rare Helicobacter, and that immunostaining Helicobacter is really sensitive. You can see 1 or 2 bugs. When the patients are on PPIs, they look different. They're round and they go down deep. So you have to look for them very carefully. But you do sometimes, you are lucky sometimes and find them. In the GI literature, they do talk about taking patients off PPIs before they do the biopsies, but I don't see them doing that.
What do you mean by round?
Like a cox, they look like a cox. It's called a coccoid form Helicobacter. That are being that little comma shape, they're really round, and you might see 3 on a biopsy. And instead of being just on the luminal surface, you have to look deep down into the glands.
All right. Do we
Yeah,
have-
thank you, Dr. Lasby. Those are great pictures. It is a great talk. Thank you.
All right. Do we have any other questions from our online participants? Or from our audience? All right, seeing none. So moving on to our business meeting, and just a couple of administrative updates. So we have our membership number has increased, but by 1 compared to last year. So we were at 68 last year, and then we're at 69 this year. So do encourage your colleagues to return. We're back in person now for about 1.5 years, I think. And so, we're happy to be able to have our members. And then Julia's giving out the financials for the group. But so far we're a lot more financially stable than what we were 3-4 years ago. And if I'm remembering that right, Julie, I think our balance right now is at $17,000. So I think when I first started with you guys, you were at about $250. So we're getting there and we're making our way out of the financial hole that we were in. So we're happy to be able to host our industry partners to help us out with that. And obviously your membership dues help out with that as well. And included in those are last year's to date and then to date. With regards to the NMA, a legislative update, there's a lot of buzz right now, as you can imagine. There's a lot of pretty controversial bills that were put forth this year. A couple in particular that have kind of stalled the legislature as a whole. A couple of senators have been filibustering because of these controversial bills. And so not a lot has gotten done. We are in our long session this year. So it's a 90-day versus a 60-day session, which means that they will be going, I believe, through mid-June at least. And so at that point, by law, the only bills they have to pass are the budget for this year and next. Otherwise, they really could spend the rest of their days not passing any bills if the filibuster continues or if they're at an impasse. A couple of things that we're looking at from an NMA perspective, definitely the liability excess fund is in trouble right now. Mostly Senator Wayne, if he's in your district, please feel free to share your thoughts with him. But Senator Wayne has proposed a bill again to remove the cap on your physician liability or multiply it by 10 times. And so that obviously affects every physician in the state, would make Nebraska less of a physician-friendly state, increase your costs. And so our approach as the NMA has been to kind of look at the excess liability fund, try to find a happy medium of how much liability you guys should carry, how much the hospital should carry, and have that be a way for us to stop Senator Vargas's efforts to remove all caps. I will point out that he is also a trial attorney who does these types of cases. So I don't want to say that there's a personal investment in there, but there might be. And then one of the other bills were obviously following the controversial ones because they do dictate how physicians practice, regardless of where your personal thoughts on the issues might be. But our approach as the NMA is really making sure that the legislature is not in charge of how physicians practice medicine. And so if you have questions about that, I'd be happy to help answer or lead you to the person who would have the answer for that. Another bill that just moved on to first round of debate, which was surprising, was telehealth parity bill. And so, which interestingly got lumped in with a pet insurance bill. And that's how they were able to get that through. So I think that the senators, knowing that there'll be a lot of, opposition and it'll be very slow this year, have kind of found unique and innovative ways to try to get movement on their bills. And so telehealth parity, payment parity is obviously important for us. And so those are kind of the ones that we're tracking that I think would affect pathology probably the most. But if there's any that you need me to take a look at, I'd be happy to reach out to our lobbyists to help inform the group on them. The NMA annual meeting, if you're an NMA member, is August 18th, 2023. So you'll probably be starting to see the save the dates on that pretty soon. The CAP meeting, CAP 23, is October 7 through 10. Dr. Thompson, I don't know if you have any additional CAP updates you want to include.
The House of Delegates is meeting this weekend. Is anybody registered?
House of Delegates is meeting this weekend. Dr. Teigmeyer will be participating. All right. Now to our big topic of today is elections. And so as you might recall from your bylaws, elections are every 2 years in the springtime. And so I'm sorry, I couldn't make that a lot bigger based on this. So I hope you can see that, but we will need to elect a president-elect, up to 3 at-large members, but at a minimum 2. And then Dr. Lacey has been our state issue advisor. And then we also have CAP delegates and alternate delegates. And so yes, Dr. Thompson.
So if you are a CAP member, I should say, we did put forth 4 delegates to vote on. There was a 5th person, I believe, that when I contacted them, they said they didn't really mean to put their name into the hat. So as far as I know, the only change up there is that I will no longer be involved with the House of Delegates. The other three will be, and Deb, if you'll help me, Sarah Rutter will be a delegate. Tyler has indicated interest in being our delegation chair, so I presume that that's the way that that is going to shake out. As far as elections, we don't have many people here. Typically, we have tried to go and have officers from the different organizations to share the wealth of knowledge. And so we're going from, I was considered to be a private practice physician. We'll go back to the academics with Ben for the next 2 years. It would be nice to get someone in private practice into that president-elect position. And then secretary treasurer, I don't have anybody. Do we need to actually plug in names, or can we solicit?
We can solicit candidates
Okay,
or people could offer themselves as candidate, and then we can provide either an online poll, or if you feel like we can
Okay.
vote here, we can do that as well.
so I think because we're a very small group, what I would like to do is send a separate email requesting nominations or volunteers. And depending on that, it might end up being a voluntold. And hopefully that person will graciously accept, but that may be the way to go, unless anyone has any other input or suggestions. I'm all ears.
Is that acceptable by our bylaws to do it that way?
I'm sorry.
Is that acceptable by our bylaws to,
You know, Wayne is, I'm looking at Wayne because he's here. He's usually our bylaw guy. I have no idea, Steph, but you know, at this point, I'm kind of to the point that if you're willing to step up to the plate, that we would love to have you. Because unfortunately, our volunteers, the pool just shrinks every year.
Mhm.
So we're kind of to the point where I have no idea what those bylaws say. We probably aren't following them, but we're doing the best we can. Yeah.
So yeah, per your bylaws, there should be a nominating committee. The nominating committee then gathers these. However, the bylaws also state that if there are empty spots, the current governing body can choose them. And so we've never had nominating committees, so we've been functioning by way of allowing people to submit their names for candidacy or submit their colleagues' names for candidates. So
Okay. So at this point, we've got the CAP is in place and we should be good there. They will, I believe, officially vote at the House of Delegates meeting this weekend. So that should take care of that. And then we will follow up with an email to all of our NEP members and move forward from there. I won't stick you with it, Ben. We'll get it taken care of before the fall. Is that it?
I believe so.
Open. Anyone have anything else? Oh, Dr. Greiner?
Do we have somebody in this WPS Medicare?
Min Mays took that over from you, and I have not touched base with her, so I will do so. I did, I was talking with a couple in the hallway. I did receive an email from the CAP just today, and in honesty, I haven't studied it as closely as I need to. But essentially, they were asking if there are people that are GI or GU specialists that would potentially be willing to prepare a presentation to the Medicare, what do they call them? It's the
CAC.
No, it's not the CAC, but it's the Wisconsin Medicare that we are all under. And it's for reimbursement purposes because of them not making payments in those areas. And my quick perusal, it implied that part of it was about MMR testing. in colon cancer, that it's currently written in such a way that it is not in sync with what the CAP would like. And for GU pathologists, it had to do with multiplex staining on prostates in cases of essentially atypical small acinar proliferations. I believe they listed 4 different insurance agencies that I guess are evaluating the reimbursement in those areas. And the Wisconsin, whatever those other names that go with it. I'm sorry, I'm not as well versed in that as I would like to be. Wisconsin was listed as one of them. So it sounded like the GI had probably been put to rest, but now they're kind of moving on to the GU arena. Anybody else have anything else? It sounds like they were going to adopt the CAP's stand that you could do that MMR testing in individuals. I believe it was written for under 70 and they wanted to be any individual, or it include the individuals that are over 70. And I believe that, I know Cigna, I think, is the insurance company that said that they did agree to that. They did not specifically say that the other 3 did, but the call that I got, or the brunt of the memo, was more that they're more worried about the GU at this point. So I think I know pretty much most of the folks that practice in that area. I'm happy to forward it on to see if anyone else has any other thoughts on it. Anything else? Okay. We're adjourned. Thank you.
Thank you. Thank you, Dr. Thompson, for 2 years of leadership and yeah. All right. Thank you to our online participants, and we'll be in touch. Bye, Dr. Linfield.
Yeah, thank you.
Bye, Dr. Lisi.